So can be a problem because if the trach gets clogged, the entire trach may need to be removed if you cannot clear it by suctioning. So in a lot of cases, you can place stay sutures where the sutures sit off to the side of tracheostomy entrance, so that if you do need to put the trach back in, you can then pull on the stay sutures to bring the trach up to the skin and then put a tracheostomy tube back into the airway. In kids presenting with severe tracheomalacia that requires tracheostomy, the distal tip of the trach must bypass the site of the obstruction for the trach to work effectively. In adults with a normal body habitus, so non-obese patients with normal neck, you will generally be using regular size 4, 6, or 8. A size 8 would be appropriate for a very tall individual. Now, if you're not really sure, you can generally use size 6 for both male or female. For individuals that are very small, you may want to consider using like a size 4, but it's important to make sure that the size 4 is not too short, because you may run into the risk of the distal tip of the trach falling out in false track. Now, it's very important to not use regular trach for patients with very large obese neck, as regular trach is not designed for that, so that it makes it very easy for the trach tube to slide out and result in a very dangerous false tract from forming. Proximal XLT increases length from the skin to the trachea. And it's designed for patients with very large neck, or maybe a patient had a pectoralis muscle flap with a significant muscle bulk that transverse close to the clavicle. They come in sizes of proximal XLT 60, 70, and 80. 80 being larger than 70 and 70 being larger than 60. Distal XLT increases length from the trachea to the carina. So this is useful in patients with tracheostenosis as long as you know that the distal tip of the tracheostomy tube is further distal or closer to the carina than the stenosis that's present. This will stent the airway open. It comes in size 60, 70, and 80. Again, 60 will be smaller than the 70, and 70 will be smaller than the 80. Next question being, how do you determine if someone has a distal tracheostomy tube that is a proper size for that patient? So let's say you have a patient with a tracheostenosis. The tracheostenosis is causing narrowing of the airway from the tracheal lumen being smaller at the site of the stenosis. In that situation, you'll start out with the trach for the tracheostomy tube to be placed later. Once you have a tracheal opening, you can then look with the flexible bronch, and the goal is to reach the site of the tracheostenosis, and you want to go slightly past the site of the obstruction where the tracheal lumen opens back up to normal size. At that point, with your finger, you want to pinch at the level of the skin where the flexible bronch meets the skin opening. Once you take the scope out, you can then measure from the distal tip to where you had grabbed on the bronchoscope at the level of the skin opening. This tells you the distance from the skin opening to the site of the tracheostenosis. Next, you'll look at the packaging for the distal XLT trachs and look at the length to ensure that the length of the trach is transversing and going past the site of the obstruction. So in this case, the length is 10.5 centimeters, and this should be long enough to bypass the site of the obstruction. Once you know the right size to use, you can use the properly sized distal XLT and place it into the airway, and then use your flexible bronchoscope again to ensure that the distal tip of the tracheostomy tube is bypassing the site of the stenosis. Next, we'll discuss phonation with tracheostomy in place, as well as the capping process. When you have a cupped trach and you inhale and then exhale, majority of the air will come out through the trach and not into the oral cavity. Thus, you will not be able to phonate very well with cuff inflated. Now, when you have a cuff down or in a cuffless trach, when you inhale and exhale, some of the air will come out through the tracheal opening, while some of the air will be pushed around the trach tube and into the oral cavity and come out of the mouth if patient is talking or phonating. There's a device called Passamere valve, which is an attachment you can place on the trach. Pacemaker is a one-way valve that allows you to inhale, but when you exhale, it prevents the air from coming out through the trachea opening, and instead it diverts the air around the trach tube into the oral cavity and come out of the mouth when patient is talking or phonating. So this is a device that helps patients phonate while the trach is still in place. Contrastingly, a red cap is a device you can put on the trach, and this prevents the patient from inhaling or exhaling through the tracheostomy tube. And instead, patient is using their normal airway to breathe around the trach tube. It's commonly used to see if a patient is a candidate for decannulation or removal of the trach. Thus, red cap only should be used on patients who no longer needs the tracheostomy tube to maintain stable airway, and is generally done by downsizing the tracheostomy tube to make the trach diameter smaller so that the patient can breathe easily around the trach tube. Once patient is able to tolerate capping for 24 hours or more continuously, patient may then be assessed to be safe for decannulation. This concludes part 1 of the basic tracheostomy talk. In the next portion, we'll be discussing decannulation protocol in greater detail, as well as common tracheostomy-related complications that you should be aware of. Thank you for watching, and I look forward to seeing you in the next lecture. We'll be covering the surgical steps involved in performing routine adult trachs. First structure you'll encounter is the skin and the incision. Once you go through the skin, you'll encounter subcutaneous fat. In obese neck patient, you have to core out a tract of subcutaneous fat to expose the trachea below. Next layer down is platysma. However, for most patients at midline, there will be no platysma present. As such, the next muscle layer down will be the strap muscles. Superficial to strap muscles, if you encounter vertically oriented vein, most likely it's going to be anterior vein. This structure can be safely tied or clipped if it's in the way. Once you encounter the strap muscles, you want to divide the strap muscle vertically at a naturally existing dissection plane between the left and right strap muscles. Once you go past the strap muscles, you should palpate for the cricoid, and it's important to stay inferior to the cricoid to avoid injury to laryngeal muscles. Depending on the patient and the size of the thyroid gland, you may see the thyroid gland sitting on top of the cricoid. Your goal is to divide the thyroid at midline to expose the cricoid and the trachea located deep to it. Once you reach the level of the trachea, you should then identify the second and third tracheal ring, which is commonly where the tracheal opening is made. Next, we'll discuss each of these steps in greater detail before proceeding with the surgical video. Orange lines mark the medial end of the sternocleidomastoid muscle. Next, we'll palpate for the sternal notch and the cricoid. This helps you identify the second and third tracheal ring, where you'll be aiming for tracheal opening. For planned tracheostomy, we'll be making a horizontal incision located medial to the sternocleidomastoid muscle. For an emergent trach, you'll be using a vertical incision, which will help you identify different levels of trachea easier. Another thing to keep in mind is if you're performing a modified neck dissection, you want to make sure that the neck apron incision does not communicate with the tracheostomy incision. The exception to this rule is when you're performing total laryngectomy with bilateral neck dissection. In that case, the tracheostomy incision will be included as part of the apron incision for total laryngectomy. Once you cut through the skin incision, next layer down is the subcutaneous fat. As you go through the subcutaneous fat and before reaching the strap muscles, you may encounter vertically oriented blood vessel, and most likely this is going to be anterior vein, which are located superficial to the strap muscles. In some patients, anterior vein can be quite large, but they can be safely sacrificed without any complications. If you stay midline, most likely you will not encounter any platysma, and instead encounter left and right strap muscles. Once you reach the strap muscles, your goal is to identify natural existing tissue plane called midline raphe, which is a bloodless tissue plane that you should be dissecting to reach the thyroid and trachea. Once you separate the strap muscles and approach deeper structures, it becomes critical to identify your midline and the cricoid cartilage. You can achieve this by first palpating for the thoracartilage, which is quite prominent in most patients. Follow it down inferiorly until you feel an indentation where the cricoid thigh membrane exists. Cricoid thigh membrane also marks the midline reference point. Immediately inferior to the indentation will be your cricoid cartilage. At the inferior margin of the cricoid cartilage, there'll be another step off where the first trachea starts. The reason why it's important to stay midline is to recognize that there are important structures that you want to avoid injuring located lateral to the trachea, namely carotid artery and the recurrent laryngeal nerve. Carotid artery is located lateral to the trachea, and you can generally palpate for its pulsation if you're not sure exactly where it's located. With that said, carotid artery is not typically seen during routine tracheostomy, and if you're seeing it within your surgical wound, it means you have drifted off way too far lateral.